here at SCRC Fertility. This month, October, is Breast Cancer Awareness Month. Very happy to be here with you today to speak about Oncofertility, fertility preservation for women with a cancer diagnosis. More and more women are diagnosed early, especially for breast cancer, which is amazing. It leads to so many early life-saving treatments like early chemotherapy and surgery and treatments that are now giving women a long, healthy life after their treatment, which is so incredibly amazing. One of the issues to think about, however, with chemotherapy and exposure to those sorts of things for, again, life-saving treatments is that it can actually affect a woman's egg supply. Women are born with all of the eggs they will ever have. So unlike men who produce sperm throughout their lives, women are born with a certain number of eggs. Now, we're born with a lot of eggs. We're born with hundreds and hundreds of thousands of eggs, or actually we start puberty with hundreds of thousands of eggs, and we have more eggs than we could ever use. But as we get older, we lose eggs in number, and we actually lose eggs in quality as well, meaning that the chromosomes in the eggs undergo changes, which makes it harder for women to conceive as they age. But fertility is not just linked to chromosomal issues, it's also linked to egg number. And so as we get older, we lose eggs in number. And so if there are things during our lifetime that accelerate the egg loss, so certain environmental exposures, toxins, radiation, chemotherapy is actually one of those exposures that can lessen our egg supply. And with less eggs in our ovaries, we will potentially undergo fertility issues at an earlier age than we would have otherwise, and also potentially menopause at an earlier age than we would have otherwise. And so when women are diagnosed with cancers such as breast cancer, and they're offered treatment like chemotherapy, which can improve and save a woman's life, the thing to think about is the effect potentially on the eggs. And so many women are referred to me after a cancer diagnosis, oftentimes before their exposure to chemotherapy, to undergo either an egg freezing cycle or an embryo freezing cycle. So in both situations, we will have a woman take injections, and those injections will contain gonadotropins. Those are special hormones that will stimulate the ovaries, stimulate the eggs to develop. A woman usually takes the injections for a period of about 10 to 12 days, and then during that time period, she will come to see us for what we call monitoring visits, blood work and ultrasound, to assess how her follicles and her eggs are developing, and we adjust the medication throughout that process. And then we have her, after about 10 days of medication, come to see us for an egg retrieval procedure. For that procedure, she'll be under anesthesia, she'll be asleep, she won't feel anything. We'll take the fluid out of the follicles while she's asleep, and we'll take that fluid, give it to the embryologist, and then the embryologist will take that fluid, take the eggs in that fluid, freeze the eggs right then and there, or we'll take those eggs, fertilize them, make embryos, and then we can test them and make sure they're chromosomally normal, and then we know what we have in the freezer for later potentially. The idea here is that by taking eggs out of a woman's body before she is exposed to chemotherapy, then theoretically we will have more eggs than she would have if she waited until after chemotherapy to get those eggs. And by having these eggs frozen, or embryos frozen, they don't degenerate in quality or quantity over time, so we sort of lock in her chance of being able to conceive with those eggs potentially later on, maybe after she's done with chemotherapy or after she's done with treatment, and we could use those eggs and we can fertilize them at a later point in time, create embryos, and then actually put that embryo back into her body, or if she wanted, we could take that embryo and put it potentially into a gestational carrier's uterus for a gestational carrier to carry that pregnancy for her. But by doing this fertility, we call preservation, or I don't actually love the term fertility preservation, because I think that implies that we're actually 100% preserving something, and we're in fact not. What we are doing is, by freezing eggs or embryos prior to chemotherapy exposure, we are giving a woman a greater chance of conceiving in the future than she would have otherwise. And so we're improving chances, we're increasing chances by freezing eggs at a younger age and prior to the chemotherapy exposure. So that is often something that people come to do prior to chemotherapy exposure, but women often come to see me after chemotherapy exposure. So just because a woman is exposed to chemotherapy, it does not mean she's going to necessarily be infertile or have a harder time getting pregnant or have a younger age in menopause. But it may for some women. And so sometimes if women are exposed to chemotherapy and then they afterwards want to conceive, I absolutely can help them as well. But so in those cases, sometimes we think about IVF and fertility treatment for the woman to conceive at that point in time, or again, potentially for a gestational carrier, meaning that the chemotherapy might be enough to put a woman potentially into a state of infertility, but not necessarily menopause. And so she might need fertility treatment to conceive after chemotherapy exposure. Again, really great if we can freeze eggs, freeze embryos before chemotherapy, but we can absolutely take care of a woman and try to get eggs and embryos after chemotherapy as well, if that is the situation that we are in. I'm happy to answer some questions. I think it's important to realize that as far as we know, the chemotherapy and the data that we've collected, women who've been exposed to chemotherapy don't have any greater effect on the chromosomes of the eggs or the congenital anomalies that may develop in a pregnancy. So it's not higher in those women compared to the general population. So I think that's really important to know. Again, it's more of a matter of the effect on the egg supply and the fertility rather than the quality of the eggs or the chromosomes of the eggs. So as far as our understanding is, the chemotherapy won't have an effect on that. So that's reassuring for women who want to conceive after they've been exposed to life-saving chemotherapy. There's definitely a future and a hope for these women to create a family despite exposure to chemotherapy. Any questions I could answer? I see that there are a lot of people checked in. So happy to see you here. I know this is about oncofertility and fertility preservation for cancer patients, or fertility treatment for patients who've been exposed to cancer treatments, but I'm more than happy to answer questions about egg freezing in general, or embryo freezing, or fertility preservation, or anything like that, if anyone has any questions. Any, I think just a lot of people checking in. One of the things people tend to ask, if they're going to do an egg freezing cycle, or they're going to do an IVF cycle where we get eggs and create embryos and freeze them, the question sometimes is, well, is that going to harm my ability to conceive on my own? And the answer is absolutely not. The only eggs that I can get out of your body are eggs that would have died that month anyhow. So it's really important to realize. And when I do my fertility consultations, I often talk about the basics of the menstrual cycle. So it's important that we understand our menstrual cycle so that we can understand how the treatments that were offered might have an effect on that. So in every menstrual cycle, when a woman is ovulating, there are a number of follicles. So follicles are pockets of fluid on the ovary that contain the microscopic egg. So there's a number of follicles that are sitting there on the ovary waiting to get recruited. In any given month, when we're not on fertility medications, and also when we're not on birth control pills, but in any given month, your brain secretes enough gonadotropins, enough hormones to stimulate follicles, to stimulate the eggs. Your brain secretes enough hormones so that one follicle, one egg, becomes dominant, and then that follicle, that egg, ovulates, meaning it gets released by the ovary, gets picked up by the fallopian tube, and waits for the sperm there to fertilize. If it meets sperm, great, pregnancy occurs, and then the embryo travels down into the embryo and implants. If it doesn't meet sperm, well, then 2 weeks later, a woman will get her period, and then the lining that developed in the uterus will then shed, and that's essentially what a period is. So we essentially have to understand that because we are making use of that very same physiology when we are having a woman take injections to stimulate her eggs for an egg freezing cycle. So as I mentioned, there were a number of follicles, a number of eggs sitting there in the ovary waiting to get recruited by these hormones produced by the brain. In an egg freezing or in an IVF cycle, we don't want only one follicle, one egg to get recruited and to stimulate. We want all of those follicles, all of those eggs that would have died that month to get stimulated and recruited. How do we do that? We essentially will have a woman take, in the form of an injection, the very same gonadotropins, the very same hormones that her brain produces, but at much higher doses, so that not just one follicle, not just one egg gets recruited, but all of those follicles, all of those eggs get recruited and stimulate and grow and grow and grow. In addition to gonadotropins, we'll have a woman usually take something like, it's called an antagonist, or lupron, so something that prevents ovulation, right? Because we don't want a woman to ovulate. We don't want her to release those eggs that were growing during the stimulation period. We want the eggs to grow and get stimulated, but we want those eggs to stay in the ovary, because I will then go in at a certain point and remove the eggs from the ovary, take the eggs, give it to the embryologist, and then the embryologist will then, again, take those eggs, freeze them in the lab, or we'll take those eggs and fertilize them and make embryos. The idea here is that we're making use of these follicles, we're being efficient, making use of these follicles that otherwise would have died, these eggs that otherwise would have died through atresia. We recruit them and stimulate them. And so the question is, well, again, if I do this process and you take eggs out of my body, am I going to have menopause earlier or fertility issues earlier than I would have otherwise? And the answer, again, is absolutely not. These are eggs, again, that would have died that month, and all we can do is salvage and recruit those eggs that would have otherwise died. So this can only help you, cannot hurt you. Questions? Like I don't have any questions today, but feel free, please. I mean, I think our information is in the information below. There's a link to our clinic. You can feel free to reach out to me or any other doctors here at SCRC. We're more than happy to take care of you and answer your questions. I really encourage you and empower you to ask questions from the experts, because I think sometimes there's a lot of people speaking, and I know sometimes it feels intimidating to reach out to a physician and ask a question, but I think it's really important that if you have a question, you get it answered by the person who can give you an accurate answer and give you the correct information. So if you don't have a question now, or you're not thinking of it, no worries, but please feel free to reach out after. More than happy to speak with you and answer any questions that you may have. Thank you. Have a great day.